I think maybe we should talk a little bit about like incentives and who's valuing what too, because, when we do work, with clients here at Rehab U, and we're talking about, well, let's set this up for the long term. Like we're always talking about those 4 Ps. You've got the payer, the provider, the policymaker, and the patient, right? So they each all have a different set of not only just incentives, but what they consider valuable, right?
Yes, and that's why you can't really talk about value until you say value to whom, right? If you avoid a hospitalization, that has value for a payer, it has value for a patient, but the way that you think about that value and would quantify that value is very different, right? So,
and one would argue the hospital is losing money, right? They're not billing out.
I mean, they are. I mean, and so that's the best argument to indicate that there's not a single definition of value, because benefits to some are costs to others. And you can't just talk about, oh, we're going to just increase the value for everybody. That's not always, you can't always do that. And it can be hard to measure that value. And so you need to be specific about it. And some of my critiques of some of the value-based programs are not necessarily in how they're structured, but in some ways how they're communicated. Be clear about whose perspective you're doing this from and how you're defining it, because that lets us understand, do they care about unintended consequences for patients? Well, maybe they do, but the way that they really are defining value is from a payer perspective or whatever it might be. So your example just sort of illustrates why you sort of have to think more critically than we historically have about these.
Yeah. Well, and wouldn't there be a dearth in the argument or the literature, if you would, about those other payers? I mean, or the other stakeholders, because it seems like most of the dialogue around value-based care and value-based reimbursement is really being driven by the payers who are paying for it, or like CMS, which is, I guess, technically a payer, but they do run policy at the same time, right? Those two are the big dogs when it comes to deciding how it's going to get paid for and who's going to do what. And it kind of leaves the provider and the patient kind of like, oh, what's going on?
Yeah, I mean, historically, this sort of comes from our attraction to the idea that value is just simply quality per dollar spent. And that has been a rallying cry, but that's very much from a payer standpoint. And patients get very different value from it. Yeah, they may save some out-of-pocket costs, but a lot of times when we talk about value, we're talking about non-monetary value, especially in healthcare. We're talking about quality of life. We're talking about caregiver burden. We're talking about hope. We're talking about equity. We're talking about, and these aren't just concepts. There's published literature out there that demonstrates, value and hope and value and equity and things like that. So, at the same time, even when we talk about being patient focused, we rarely talk about the responsibility of a patient. What should they be expected to do? Where does the responsibility of the clinician end and the responsibility of the patient begin, especially if we're touting these programs that are supposedly sort of patient first.
Yeah. And even on top of that too, like at what point does society, like the societal implications of that as well, like